So good evening and Shab Becher, everyone. To those of you on the West Coast, good afternoon and Ruz Becher, and Laila Tov to those of you in Israel. My name is Stephen Kadavi. I'm the president of the Iranian American Jewish Federation of New York. It's my pleasure to welcome all of you in Zoom land to our inaugural virtual event, an evening with medical experts, healthcare in the age of COVID-19, a topic that we know is of interest to many people right now. There's a significant amount of consternation regarding the current environment, and we have a stellar panel of physicians that hopefully will alleviate your concerns and answer your questions. Before we get to the program, let me just take a minute to talk about IAJF and let you know what's been going on the past few months. For those of you that are new to IAJF, our mission is to celebrate the accomplishments of the Iranian Jewish community and to invest resources to support those in need, both in Israel and the United States, and to safeguard Zionist ideals. We're also cultivating the next generation of leaders through our Young Leadership Division. Since 2002, IAJF has raised close to $58 million. That bears repeating. Thanks to the generosity of our donors, we have raised almost $58 million and distributed funds to over 200 organizations. We've provided support to IDF soldiers, victims of terror, the disabled and needy, hospitals, educational institutions, at-risk children and youth, and many other worthy causes. I'm also proud to state that IAJF has achieved a 4-star rating from Charity Navigator for 5 years in a row, as well as the GuideStar Gold Seal of Transparency, a testament to our financial stability, governance, and accountability. With the outbreak of COVID-19, we have also turned our attention to the immediate needs that have arisen. When sheltering in place first commenced, we arranged for food to be provided to those members of our community that needed assistance. We also arranged for food deliveries of over 800 meals during Passover. Finally, we arranged for over 200 Shabbat meals to be delivered to various families in need. We also started sending meals to various area hospitals as a way of showing our appreciation to the many healthcare workers that have been at the front lines of this pandemic. We used local restaurants to provide those meals as a way of providing support to establishments that have obviously been suffering financially. Finally, we led a very successful mask drive at the end of April, distributing well over 7,000 masks in a period of less than 2 hours. We're continuing to look for ways to help out during these unprecedented times. For more information about IAJF, please go to our website, iajfny.org, or follow us on Facebook. With that, it gives me great pleasure to introduce our moderator for the evening. Dr. Daniel Roshan is an IAJF board member and specialist in maternal fetal medicine. His expertise is high-risk pregnancies. He will introduce the other panelists. Dr. Roshan, take it away.
Thank you very much, Stephen. Indeed, it's a great pleasure to present to our audience tonight, an evening with the doctors. And thank you so much for your sponsorship. I'd like to thank Shahram Yaqubzadeh, our chairman, and also our vice president, Herser Torkian, whose efforts lead to this evening tonight. And also thank you to our executive assistant, Tova and Lynn, and Tova, who's with us right now, make sure everything goes well. We're going to talk about medicine in the era of COVID-19. Do's, don'ts, pros, cons, what to do, what to know, and answer your questions. Our panelists tonight are wonderful, all young doctors. Dr. Meital Barzideh, who's a pediatrician. I'm going to introduce each of them before their talk. Dr. Alan Khadavi, who's an allergist, Dr. Joseph Amirian, who's a cardiologist, and Dr. Abraham Barzideh, who's an anesthesiologist and critical care specialist. The purpose of this Zoom meeting, tonight, we touch on OBGYN, pediatrics, allergy, cardiology, critical care aspect of healthcare in Corona age. But we thought this outreach is important due to many have skipped their doctor's visit and are afraid to go to doctors or hospitals. And that creates a backlog of patients who need really to talk to the doctors, who need to see doctors. So we like to answer your questions and hopefully encourage more medical outreach in this forum to our community. We have so many talented doctors that I think they should participate in this, and they should discuss and they answer people questions, and it's a wonderful thing. And we also like to encourage you to use telehealth because now almost every doctor participates in telehealth, and you can easily do a lot of stuff over the computer or even your simple phone calls. So the topic tonight is Corona, as you all know, and coronavirus, which is Latin for crown, and basically based on the picture of this virus, because there's so many spikes that looks like crown. It's an RNA virus. There are different viruses. Some are DNA, some are RNA. This is RNA virus. To just, I know everybody knows all about these things already by watching all the news and all the Google and everything else, but we're going to touch base a little bit on it. So we just put answering the question that was asked from us. It's a highly infective virus, no doubt about it. Nobody has seen anything more infective than this. It spreads during the incubation periods. The incubation period is from the time that somebody gets exposed to the virus until the virus replicates and causes symptoms. Incubation periods could be from 4 to 14 days, and the virus could be transmitted up to 8 days after the symptoms, that by majority, but there are some rare case report that the person transmitted the disease up to 21 days, and some people can go up to 28 days. But if you say a virus will go down in the body, it's probably 8 days after the symptoms. But up to 3 weeks, I guess you have to be careful. Symptoms are mostly malaise and exhaustion and headaches and sinus pain, not much as much as they say cough and fever and chest pain. Most people get away with it with just a simple exhaustion, being tired. You feel like you want to stay home, you want to stay in bed, you don't want to get out of bed. But it could be a variety of the symptoms, as I listed it, and I'm not going to, for the sake of time, I'm not going to read the whole thing. But thank God, 25% of people who get it are asymptomatic. They don't even realize they got it. And 85% recover by just resting at home and taking it easy. So that's a good news, something we probably didn't know at the beginning when the virus just came out. And we had many people with panic attack. As soon as they heard somebody was were near them, was just tested positive, people start breathing fast, people start sweating, people start getting symptoms of COVID. And some people even called me, says, oh, I'm hyperventilating, I'm sweating, I'm exhausted, I think I have fever, what should I do? And it was basically a panic attack. So I think now we have less and less of it. Now, testing is available. Despite that, say testing is the most important things for reopening, testing is available because many urgent cares and now doctor's offices, including my office, we can offer testing to anybody with both PCR and both for doing antigen antibody testing, which is IgG and IgM. IgG basically is a sign of immunity, permanent immunity. IgM comes first when a person gets exposed. Now, the question that many people ask, okay, I just had Corona and I recovered and no problem, and I have antibody in my blood. I tested it, I have IgG. Now, am I okay? I can just go do whatever I want? And unfortunately, the answer is that the positive IgG doesn't guarantee protection against future disease. However, having said that, if you are tested positive with antibody, you are definitely less infective to others. You are definitely a stronger person because you already got it and recovered. If you get it again, you could, because it could be different serotype, but it's going to be much, much weaker presentations. And this is the most likely thing. Although if you ask many, it says, we don't know. But I think if you have the immunity, you're a little bit more protected, but you cannot be off guarded. You cannot not wear a mask, not wear gloves, and all the precautions. You still have to continue with all the precautions. When to seek medical help is basically, we're going to have this part more explained by our panel, but the high fever, chest pains, shortness of breath. If you're a high-risk patient, all the risk factors, you should call your doctors. There are different treatment options, which I'm going to leave that for our other panelists. Now, people ask, what makes patients very sick? Well, what is the reason that people die? And I must say, this is mostly older patients. The virus causes severe inflammatory reaction in the body, which leads to severe pneumonia. It causes lung failure, heart failure, renal failure. Many are being shown to have blood clotting. That's why we treat all the patients who get admitted with coronavirus, with COVID-19, with anticoagulant, mainly Lovenox. And Dr. Amelian will touch a little bit more on different medications. And also there's a component of superimposed bacterial infection. Many will develop other bacteria because the body gets very weak and develops sepsis and die from that. Now, as we said, the best intervention is prevention. and the best is not to get it if you obviously have a choice. So all you guys know about hand washing, wearing masks. By some studies, say masks are 75% protective against getting coronavirus, but it's controversial still the exact number. But there are different kind of masks, but the one that you need to wear if you're in contact with the real sick patients, like the doctors, is the N95 mask. But for a layperson on the streets, any face covering is protective. Regular surgical mask also protective. Keeping 6 feet away, wearing gloves, very important, not to touch with your bare hands. When the things reopen and you go to work, you go to office and you open any door, anything, make sure you have your gloves on because the virus could stay on the surface, especially in metal area, they say up to 72 hours. So wear gloves, wear the mask all the time. That should create great protection. Don't touch your face. As you can see the panelists or me tonight, as we talk, we're going to keep touching our faces. That's really a bad habit, and you have to work really at it to not scratch your faces. So don't touch your face. Wear gloves and don't touch your face. Now, for all elderlies, especially those who are, let's say over 75, and so I think the best is to stay home until you're vaccinated or the vaccine is out. But if you have to go out, again, mask, gloves, be very careful. Now, people ask, what should we eat to prevent getting corona? What is the immune system booster? So vitamin C, vitamin D, zinc, and many other things like berries, natural berries, garlic, onion, as things that will improve the immune system against coronavirus. Also, and many people are staying home and they keep drinking and they think, okay, I have nothing else to do, let me enjoy my life. But alcohol really decreases the immune system. So you have to be very careful to decrease the amount of alcohol intake. And smoking, absolutely. If you need a time now to stop smoking, now is the time because smoking will increase your chance developing a morbid COVID-19. Many ask us about the vaccines and other therapeutics, million-dollar questions. Everybody knows, wants to know what is the vaccines, when is it coming? Now, there is over 90 companies around the world with many $billion of support from different origins that are about to make the vaccine. But only 7 so far started human trial, and what we call it in the phase 1, which should be about 3 phases. The leaders that we know in vaccine production right now is Moderna, which might not be foreign to you guys because knowing that this week about a lot of news on them. Basically, they did a phase 1 trial and they had 45 patients who received the virus in different dosage, but they all developed antibodies. So that was very favorable for the public. But there is no peer review. There's not really studied yet, and it's very primitive to say if they're going to be the leader who make the vaccine. The vaccine they make is made from mRNA, a messenger RNA in the virus. So it's not a live virus, and so it doesn't cause you get the disease. And it stimulates your body enough to protect antibody. Now, the other company who's the front line is Pfizer. Pfizer is a big company, has a lot of money to do it, and they already started human trials, and many hospitals and medical centers in New York are in partnership with Pfizer to help them to recruit patients and people who are volunteering for the vaccine. When do you think the vaccine is going to come out? This is million-dollar questions. Now, as you guys know, this is going to be very expedited because the whole world is involved. And we probably need it as fast as possible. And also politically motivated because this is the election year. And the sooner it comes, the better it is. So if I have to bet, I would leave it to audience, so I'm not any better than anybody else could guess. I would say anything between November to February of 2021, that probably should be a vaccine on hand. The other things people ask about the synthetic antibodies. There's a company called Sorrento Therapeutics, which also was in the news this week, that they make the antibodies. Your body, after getting exposed to the virus, makes IgG, the antibodies, which is becoming a reference. So every time the virus comes in, these antibodies attack the virus and get rid of them so you don't get sick. So this company had a good idea. They said, why don't we make these antibodies synthetically, monoclonal antibodies? And then through the IV, we have to give it to the patient who are exposed to COVID-19 and improve their health. So it's still research in process. Another company, which is Israeli actually, Pluriostem Therapeutic, PSTI, is working on making a stem cell therapy, which is stem cells could cure many things. And one of the things is the coronavirus. Now, as my specialty and as an OBGYN and high-risk OBGYN maternal fetal medicine specialist, many people send me questions on pregnancy and COVID-19. So questions, variety of questions, but the one I think more pertinent to mass public and people want to know more about it is how does it affect the pregnant mothers? So far the answer has been like pregnancy, usually pregnant patients are more prone to getting illnesses. Such as flu and others. But for this disease, the COVID-19, they were the same as general public. Why? Mainly because the pregnant mothers are younger. They're under age 45, more mainly, maybe 20s and 30s. So they're young groups, and they're females. The females are being at less risk of mortality than the males. So that's been the two protective items for the pregnant patients. Now, does it affect the baby? So far, no transmission through the placenta from the mother to the baby, although some new case reports coming out, there might be such a thing. So far, we haven't seen anybody isolate virus from the placenta, but there was some case report that coming out. But so far, so good. Any birth defect? So far, no reported birth defect. Should I get pregnant? They ask me many times, should I get pregnant now? Well, if you're young and healthy and you have time, I would say wait 6 months, 9 months. But if you don't have time, you're older and the clock is ticking, I don't see any harm to get pregnant because the OBGYN offices are still quite safe. Everybody follows the social distancing, 6 feet apart, not making the waiting room too crowded. If it gets too crowded, we ask the patient to stay outside or stay in their car and we call them in. And so there's still offices and hospitals are quite safe and you shouldn't worry about coming to the doctor's office. Should I deliver at home? Many people ask me, including doctors, I'm afraid of corona, should I deliver at home? I think delivering at home is associated with a lot more risk than delivering in a hospital. So what if the baby's heartbeat drop? What if a complication arises? Do you want to have no choice? By the time it comes to the hospital, it might be too late. So no, delivering hospital is a lot safer at home, and still is better to deliver in the hospital. Hospitals do everything they can to clean, and these are the people that they know how to clean, and they know how to disinfect, and they know how to protect you. Who could come with me when I'm in labor? Many people ask. Well, at the beginning, some hospitals closed to everybody except the pregnant patient, not even husband, but government Como reversed that, and they allowed the husband to come in. At our hospital, the husbands were always allowed to come in unless they were sick. And now, this week, they started also allowing a labor coach or certified doula to come in also. So the husbands and doula could come in with you, but not the rest of the family. And can I be with the baby? Can I breastfeed? Well, if you're not sick, of course. If you are sick and you're tested positive, by the way, everybody who comes to labor room now gets tested for COVID-19. So they know everybody who's positive, who's negative. If you are positive, and you have symptoms, they encourage you to not be close to the baby, or if you are, wear a mask and gloves and be careful. And they encourage not to directly breastfeed unless you insist, which they're not going to stop you, but you can express the milk and bottle feed. They ask, are there more C-sections nowadays? No, there are not more C-sections. Everything is the same as labor and delivery. When I go to labor and delivery, it's the only place I feel like is business as usual, so no problems. But if the patients who have COVID-19 are very sick, they go to ICU, then they are sometimes indicated to be delivered earlier, so the mother could be taken care of more properly. So there are cases that patients deliver prematurely or they had a C-section to improve the health of the mother. Now, high-risk patients, please don't skip your office visits or use telehealth to your advantage. Talk to your doctor, ask them what is the safest, longest interval that I can see you in your office. That would be the best policy. But if you're high risk and you need to be seen, otherwise your baby could be at risk of fetal distress or stillbirth, please continue to see your doctors as indicated. Gynecology patients also ask if they have a condition like a lump or something that's been followed, please continue to follow it. If you have pain, lumps, irregular bleeding, anything alarming, use telehealth first. You can call you can call your doctor. You can use Zoom. You can use many technologies to connect, and they will tell you whether you should come in or not come in. We promise not to go too long, so we'll try to speak fast and speak clear at the same time. Now I'm going to turn the table to Dr. Maytal Barzide, who's board certified in pediatrics. Dr. Barzide is assistant professor at Albert Einstein College of Medicine and the associate residency program director at Jacobi Medical Center. Dr. Barzide, please take it away.
Thank you so much for having me. I'm just trying to share my screen here. Sorry. Okay. Thank you so much for having me. It's a pleasure to be here and to discuss this important topic with you all. I'm going to be talking about COVID-19 and children. So we do know that there are cases, pediatric cases of COVID-19, but we also know that it's not as common in children as it is in adults. About 2% of the confirmed COVID-19 cases in the US are in children under 18 years of age. Now, their symptoms vary. They can be asymptomatic, or they could their symptoms could be very severe, but for the most part, their symptoms are mild and are that of and are typical of a common cold: fever, cough, congestion, that kind of thing. We do see childhood hospitalizations, but they are very rare. Most of the hospitalizations that we're seeing are in kids under 1 year of age. And those are the kids who actually do end up having some comorbidities like heart disease, lung disease, stuff like that. And of the cases that we're seeing, only about 0.6% of these kids end up needing critical care in an ICU. So it's a very small percentage. This is the new hot topic that's out there in the news. People are asking me about it. You know, the new kind of entity that we're seeing in the pediatric world with COVID is this new pediatric multisystem inflammatory syndrome, or PMIS. So what exactly is PMIS? We know that it's an inflammatory syndrome that's similar to Kawasaki disease and also similar to toxic shock syndrome, but it's not exactly the same thing, and I'll go over why in a minute. The syndrome can lead to shock and organ failure in children who come down with it. We do know that it is related to COVID-19. Most of these kids either have the COVID-19 virus, their PCRs test positive, or they have the antibody for COVID-19. So what that suggests is that this is actually a COVID-19 or post-viral hyperinflammatory.
I'm sorry, Maytal, we can't see your slides.
Oh.
It's okay, you're doing well.
You share the screen.
Slides. How about now?
Yes.
If you want, just show us the slides from the beginning that you had, but just let it run through because you already talked about it.
Sorry. COVID-19 and children.
Yeah, go ahead. Go to the next slide. So continue.
Okay, so we know that this is, or we think that this is like a post-viral hyperinflammatory response. What that means is that children get over the virus, and then several weeks or even sometimes even a month after they recover from the virus, that's when their immune system kind of goes into overdrive and causes all the problems that we're seeing. PMIS is different than Kawasaki disease in that it actually targets an older population. So the kids who are hospitalized are typically between 8 to 14 years of age with a median of 11. Whereas the Kawasaki kids typically are younger. And the therapies, if a child is admitted to the hospital, target the immune response. So medications like steroids, IVIG, anakinra, these are all medications that will decrease the inflammatory response in your body. So again, this is very new. It's an evolving syndrome. You know, we're learning more about it every day. There's little data on mortality, but we know it's rare. Just anecdotally, in New York State, there's about 150 cases of PMIS, and we know of 3 deaths so far. So how is it different than Kawasaki disease? People ask me about this. So Kawasaki disease is an inflammatory disease of small vessels in the body. And if it's left untreated, it could actually cause heart disease in the future for children. How does it present? Fever for 5 days, enlarged cervical lymph nodes, which is a mass in the neck, rash, swollen hands and feet, which is redness, cracking of the lips, changes to the lips and the tongue, and bilateral conjunctivitis, which is pink eye. So that's Kawasaki, but the COVID-induced hyperinflammatory syndrome is a little bit different in that the inflammatory response is much more severe. So these kids actually end up going into shock at a much more alarming rate. And their inflammatory markers are higher, and they just get much more sick. So as a parent, what do you need to know? What to do and what to kind of look out for? The most common symptoms that we're seeing with the PMIS kids who are being admitted are high fevers for several days, rash, vomiting, and diarrhea, and severe abdominal pain. Now, these are the most common symptoms, and if you find any of these symptoms in your child, it's very important to either call your pediatrician right away or just take your child to the emergency room. What we know is that early intervention is really key. So the earlier this is recognized and the earlier it's managed, the more favorable the outcomes for these children. Other symptoms that you can see are the symptoms that are similar with Kawasaki disease that we discussed before, the pink eye, the oral changes, the extremity swelling, et cetera. So PMIS, again, it's in the news, it's a very scary thing, but it's important for parents to know, and I just want to stress that it is very rare, and that early recognition and treatment are really key to the best outcomes. These kids typically do very well once they're recognized and when they are treated, and hospital stays from my experiences is between 1 and 2 weeks. The next topic I wanted to touch base on, which I think is very important, is childhood immunizations in the COVID-19 era. We're seeing an alarming drop in vaccine rates in kids across the country. And, this is because parents are afraid to take their kids to the doctor's offices. So I just want to stress that it's really, really important not to delay your pediatric vaccines and not to let your kids fall behind. The problem with letting your kids fall behind is that once, social distancing guidelines kind of ease up, which they already are, and people start going out again, your kids can actually be susceptible to other diseases that are much, much more severe and much more deadly to the pediatric population than COVID-19. We don't want to see a measles outbreak. We don't want to see polio coming back. We don't want to see whooping cough, at alarming rates, because these are all very serious diseases, and we want to make sure that we can still prevent them. For people who are scared of going into the office, like Dr. Roshan pointed out, it's, our offices are taking the necessary precautions to keep social distancing rules and really doing the best they can to keep you safe. So please don't delay vaccines. And for those who, either can't go to the office or don't want to go to the office, telemedicine really is a great option. Most, if not all, pediatric practices now are offering telemedicine as an alternative. So if you have a question, there's a rash that you're not sure about, your child has a fever, and anything really, the pediatrician can do the visit via a video call. What's interesting is actually recently the Department of Health is actually now allowing physicals to be done via telehealth, which I think is really great. So anything from routine care to sick visits, please take advantage of telemedicine. And so the main takeaways that I want everyone to impress on everyone, COVID-19 in children, it's still very rare, but it's also very important to recognize the symptoms and to act early. Early intervention, early management leads to far better outcomes. Again, the symptoms to look out for: fever, rash, severe abdominal pain, vomiting, diarrhea. These kids are, having the GI symptoms more commonly. There's an increasing role for telemedicine in this COVID era, especially in pediatrics. And please, I can't stress this enough, don't let your kids fall behind on their shots. So let's continue to keep our kids safe and healthy, and thank you. Oh, Daniel's on mute.
Thank you so much, Maytal. That was a great presentation. Our next presenter is Dr. Alan Khadavi. Dr. Khadavi is a board certified in allergy and immunology and pediatric allergies. Dr. Khadavi currently practicing in Los Angeles. We're pleased to have him with us tonight. Thank you so much for joining us. Alan, take it away.
Thank you so much for the IAJF board for having me come to this talk, and I'm excited to be here. Okay, just going to share this. Okay, so I'm going to be talking about coronavirus, how it pertains to allergy, asthma, and immunology, my specialty. Coronavirus and allergy can be confused a lot. The symptoms are very similar, a couple of them, coughing and runny nose, but those are the only ones that two overlap. Many of the other symptoms are exclusively to allergy, like sneezing, itchy eyes, runny nose, and itchy eyes. Coronavirus has obviously different symptoms as fever, shortness of breath, or body aches, or sometimes sore throat. And we've also been seeing loss of taste and smell, and sometimes gastrointestinal symptoms like diarrhea. So, but the bottom line is if you're having fever or coughing or difficulty breathing, you should call your doctor, and that's not allergies. Many patients with asthma also have a lot of concerns. If you have asthma, are you more susceptible to developing coronavirus, or will you develop a worse outcome? The actual answer is no to both of them. Asthma is not what we call a comorbidity for coronavirus. Other diseases such as diabetes, high blood pressure, and obesity are the leading diseases that seem to have worsened coronavirus patients. A lot of patients also who have asthma are concerned whether they should take steroids or not. So there was a lot of news about how oral steroids can worsen patients who have coronavirus, but this is different from inhaled steroids that asthmatics takes. Asthmatic patients should not be stopping their inhaled steroids, and they would obviously need to continue them during this whole pandemic. Now, this graph is probably one of the most important graphs that I want to talk about, and it shows that what happens when you first get sick and what develops in your body. The first step, there's two ways to test coronavirus. One, as you hear about in the news, is the nasopharyngeal swab, where this actually checks to see if the RNA of the coronavirus is in your system or not. Coronavirus predominantly resides in the nasopharynx, and when you do that test, it checks for it, the RNA, and if the genetic code is there inside of you. There's also the blood test, and the blood test checks for the antibodies in your blood after coronavirus. So at the first step, when you get coronavirus, usually up to a week, you won't have any symptoms. But then once you start getting the onset of symptoms, there's something called the IgM. The IgM is the early antibody, and this early antibody is what you measure first in the blood, and it shows the first sign of coronavirus. But what gives the long-lasting protection against coronavirus and immunity is this IgG antibody, and this develops anywhere between 14 and 21 days. So all the blood testing now that we hear about, IgG testing, is this antibody which develops 14 to 21 days after. And then this goes up after the patient begins to recover, and then it eventually, well, this is the big question, is how long does the IgG antibody last? Unfortunately, we don't know the answer to that. Obviously, we hope it lasts a long time. Other viruses that we know about IgG antibodies, such as chickenpox, you get that once in your life. Your IgG antibody lasts indefinitely. Sometimes mono, measles, rubella, a lot of these antibodies are lifelong, or some of them obviously can need a booster shot. But the big $1 million or $1 trillion question is how long this IgG antibody lasts. So a lot of studies are going to need to be done to see how long they last for, and when the vaccines come out, how long the IgG antibody going to last after receiving them. Since I'm in California and all the other panelists are from New York, I just wanted to give a snapshot of what's happening here. We've had about 80,000 cases, 3,000 fatalities. Majority of the cases are in Los Angeles, about half of them. We had an initial spike, and now it seems has to level out a little bit. In terms of a typical vaccine timeline, it can take somewhere anywhere between up to 15 years to develop. Sometimes it usually starts with research, clinical phase, phase 1, phase 2, phase 3, which we've all heard about before. And it takes a long time. But the White House has released Operation Warp Speed to condense this whole vaccine schedule to almost a year. There's about over 100 research projects working on this vaccine to develop something that's safe and effective. And we've started already developing phase 1 trials, and some are going to phase 2. As you can see, North America has a lot of research undergoing it, and other parts of the world as well too. And this worldwide scramble is to create a vaccine against coronavirus, and we're hoping it comes sooner. As you've been seeing in the news, sometimes it can go up. They're trying to develop one which in about 3 or 4 months, which is optimistic. There's different ways to coax the immune system to develop antibodies. One, as Dr. Roshan was talking about, was that RNA but most vaccines that are developing are trying to target those spikes in the proteins of the coronavirus. When you develop the antibodies, those IgG antibodies, which we spoke about, are going to latch onto the spike and destroy the virus. There's also a lot of questions about whether coronavirus can mutate. Thankfully, we haven't seen that huge of a mutation. So once you develop these IgG antibodies and a vaccine is developed, more likely than not, these vaccines will be effective. The only question is how long, how often they need to get a booster shot. It could be yearly, or sometimes it could be 5 years or 10 years. We don't know, and all the research is undergoing for that right now. And a lot of it is to be continued. Thank you very much.
Thank you so much. That was a great presentation. Thank you, Alan. Our next panelist is Dr. Joseph Amirian. He's a board-certified cardiologist and electrophysiologist, and he's a partner at Manhattan Cardiology. Dr. Joseph Amirian, please take it away.
Okay, they didn't see me when I was
Thank you very much to everyone at the AIJF for having me this evening. I'll be talking about COVID-19 as it relates to cardiology and internal medicine. First, I'm going to talk about the patients at highest risk. Then I'm going to talk about the cardiovascular complications that we see with COVID-19, when to seek medical attention if you're a patient watching, or when your family member should seek medical attention, and then possible treatment options as well. We know the patients at highest risk are those that are most vulnerable: the elderly, over the age of 65, heart disease, specifically coronary artery disease or heart failure, underlying lung disease. There's controversial data with regards to asthma that Dr. Kadavi just covered. Hypertension is an independent risk factor to put people at higher risk when they contract coronavirus. Diabetes, cancer, and not just cancer, but also people that take medications that lower their immune system. And obesity is also an independent risk factor for people to do worse if they contract the virus. The cardiovascular complications are very important. When we think of coronavirus, oftentimes our main focus goes towards the lungs. We can have scarring or fibrosis of the lungs that lasts weeks after we actually no longer are holding on to the virus. But the heart can be affected as well. It's noted that up to 1 out of 5 patients can have myocardial injury as a result of coronavirus, and we actually see this in the office. We also know that patients develop blood clots. The reasoning and the rationale behind why patients develop blood clots is not known, but many postmortem studies, specifically one at Mount Sinai, is looking specifically at this, and I'll speak more about that in a moment. We also know that the virus leads to a post-inflammatory response where the lining of the heart or the actual heart muscle can become inflamed. This inflammation leads to something called pericarditis or myocarditis, and that can last weeks after the virus has hit you. We can also have electrical instability that can occur. People can hold on to more fluids, and that can be dangerous as well. There can be blood pressure fluctuations. Patients can suffer heart attacks, and there's even case reports of aortic dissections, which were just published in the American College of Cardiology. The myocardial injury that we see can lead to cardiomyopathies. It's not clear what causes the myocardial injury, whether it's the virus itself or the stress from the virus. When to seek medical attention. We know that most patients will present with fever, sore throat, and cough, and their symptoms are going to be mild. And with staying at home, rest, and hydration, they'll overcome the virus. But there are other key specific signs and symptoms, and you have to listen to your body. If you feel significant shortness of breath, chest pain, if you have an altered mental status, or you have blue lips, that can indicate that your oxygenation levels have severely decreased, and you need to contact your physician right away or go to an EMS right away to go to an emergency room. If your symptoms are mild or you want to speak to your physician, there are telehealth options available and phone consultation options available. For example, at our office, we do that as well. And then you have to also contact your physician with any key signs and symptoms, such as unilateral leg swelling. Earlier today, I had a patient with unilateral leg swelling. She has a deep vein thrombosis after having COVID weeks earlier. Possible treatment options and safety. We know that hydroxychloroquine is an anti-malarial and anti-inflammatory agent with immunomodulatory properties. It's used in lupus, rheumatoid arthritis. This oral medication shows promise in those with mild and in the early stages of the disease, especially in small studies in Italy. However, there's mixed data, and there are serious side effects with regard to this medication. Cardiac arrhythmias can occur, kidney issues can occur, eye issues, ophthalmological issues can occur as well. So this medication is not currently FDA approved. It should not be used as a preventative medication until we have more data. And every patient needs to have specific individualized care. So if you and your provider decide that you should be on this medication, you will need close monitoring until we have further data. Azithromycin is an antibacterial antibiotic with anti-inflammatory properties. We mostly use it for bronchitis and pneumonia. Azithromycin used in conjunction with hydroxychloroquine has showed promise, but we still need more data. The issue is that azithromycin and hydroxychloroquine can both independently lead to electrical instability of the heart and, God forbid, cause an arrhythmia and death. So when you use them in conjunction with each other, that elevates and the side effects are even higher. Remdesivir is an intravenous medication used previously for Ebola. The FDA authorized emergency use of this medication in the most critically ill, and it was used in a compassionate use way. What does that mean? That means it wasn't part of a controlled trial. Gilead released phase 3 data showing that there's a decrease in the number of days within the hospital with this medication and a faster recovery. But again, we still need more data. Convalescent plasma. The FDA authorized investigational use of antibodies from a person who has recovered from COVID-19 that are given to the most critically ill. And more data is being collected with regards to this. The Mount Sinai Hospital has an excellent program for anyone who's listening who would like to potentially donate their plasma. Zinc and vitamin C have been shown as an inpatient and as an outpatient to potentially speed up the recovery. An anticoagulation is under investigation currently at the Mount Sinai Hospital in stage 3 of the investigation out of 6, and potentially shows promise, specifically with Eliquis, where they give anticoagulation to patients who are in the hospital and up to 2 weeks after they leave the hospital to prevent the blood clots that I mentioned earlier that could potentially be lethal. When we talk about zinc, we can tie in hydroxychloroquine. Hydroxychloroquine works in multiple ways, and I'm covering this because hydroxychloroquine has been all over the news recently in the past few days. Hydroxychloroquine works on the cell membrane to increase the permeability of zinc into the cell. Once zinc gets into the cell, the idea is that the zinc disrupts viral replication. It works in another way by also changing the pH within the cell, and in doing so, potentially destroying the virus. And it interferes with the S proteins that Dr. Kadavi just mentioned that bind to the ACE2 receptors that are on the target organs within the lungs and the heart that potentially lead to the infiltration of the virus into these vital organs. So hydroxychloroquine could potentially work in these 3 ways, but before we can tell you to start using it, we need more data. And its use is not recommended right now, but all care is individualized. Speak to your physician, and you guys can decide what's the best option for you. My final point is to maintain hope. This is hard for everybody, and we will get through this together, but it will take time. The worst thing to do is have a false sense of hope. We have antibody testing at the office. I see patients almost every day. We will get through this together, but it will take time. And again, the best treatment is prevention. Washing your hands thoroughly for over 20 seconds, covering your mouth, disinfecting, staying away from sick contacts, and over time we will get through this. Thank you very much.
Thank you so much, Dr. Amirian. Our final panelist is Dr. Abraham Barzide. Dr. Barzide is board-certified anesthesiologist working at North American Partners Anesthesia at North Shore LIJ Health System. He's the person in charge of anesthesia, intubation, critical care, and he will talk to us about the real sick patient once they get to the hospital and what they should do. Thank you so much, Dr. Barzida. Please take it away.
Thank you, IAJF, for having us on tonight. And thank you, Dr. Roshan, for that introduction. I'm going to be touching on the critical care and anesthesia aspects of COVID-19. As we all know, a lot of people have a lot of concerns regarding what's going on in the hospitals and whether it's safe to go to the hospital. And I will touch on a little bit on that, and also on what's going on in terms of whether when a patient gets admitted, how they will be taken care of, how they'll be clinically assessed, and what their plan of care is. So as of March 18, all elective surgeries in the United States were canceled due to the COVID pandemic. And the big question that's on everybody's minds is, when should I go to the hospital? That is a very important thing, because most of us don't know what clinical criteria needs to be met for us to make that decision to go to a hospital where there could be a lot of infected patients. So if anybody is experiencing shortness of breath, chest pain, difficulty speaking in full sentences, or difficulty walking across a room, or walking up a flight of stairs, these are all indications that you might be in distress and you may want to seek medical attention. If you have something called a pulse oximeter, something I recommend people getting, especially during this time until we have a vaccine, it could check your oxygen levels. And if your oxygen levels are low, normally below 92, 90%, that may be a sign that you're having some respiratory distress and may want to get that addressed. So patients who are very sick can have severe cases, and they can quickly deteriorate within 5 to 10 days if they're not careful and address their medical condition. So the COVID-19 is a serious illness. The mortality rate is anywhere between 1% and 2% estimated. In a study of over 2,600 patients in New York City who were hospitalized, about 14% of them were treated in the ICU. 12% of them required mechanical ventilation. Mechanical ventilation is when a patient is not able to breathe on their own for a myriad of reasons, and basically a breathing tube is placed in their throat, and then they're placed on a breathing machine. This is called direct laryngoscopic endotracheal intubation. This is something that in my profession we do regularly to give anesthesia, and it is something that has to be done when patients go into respiratory distress, as would happen with COVID-19. And the mortality rate for those who are intubated is higher than 88%, is what they're saying, at least for New York City. So the inpatient management of those who do get admitted to the hospital, patients initially come in, they're clinically assessed, they're checked for an escalation of oxygen requirement. So if their oxygen levels start dropping, they will initially have instituted non-invasive methods to deliver oxygen so that they can improve their blood oxygenation. They start with nasal cannula, then they may use a face mask, may go to a positive airway pressure device like a CPAP. Some of you may use that for sleep apnea at home. It basically forces air into the lungs and oxygen and helps patients who are in distress. High flow oxygenation has been used as well, and there has been some controversy regarding whether patients should go on a ventilator and be intubated, or they should have more conservative management with non-intubation, proning position, high flow oxygenation, and there has been some good results with that. So patients who do well on these non-invasive measures usually will recover and will not need to be, their care will not need to be stepped up. So what happens if patients don't do well with these non-invasive measures? Non-invasive basically means we don't get a breathing tube. A breathing tube is what goes into our windpipe, our airway. So if patients fail the non-invasive methods, they usually get intubated immediately, because this disease with the coronavirus, patients can deteriorate very quickly. So in order to avoid that from happening, critical care intensivists, including anesthesiologists like myself, get called in to intubate these patients so that die basically. So if they start decompensating, meaning they start breathing very hard, their breathing is labored, they breathe very fast, their oxygen levels are dropping, they may have some changes in their blood pressure, heart rate, they may have disorientation, mental status changes, can't protect their airway, there may be some fluids in the lungs. These are all indications that the disease has progressed, and this is when patients get intubated. So there's a lot of talk about something called ECMO, and a lot of people asking questions about it. What is ECMO? Why would I need ECMO? Is there an ECMO in the hospital that's in my community? Well, it's very limited. ECMO is not in every hospital. It's a very labor-intensive machine that requires a lot of different doctors from different specialties to work it. It's basically a heart-lung bypass machine. It's reserved for those patients who fail to improve on the ventilator. It is limited, and it only is useful if a patient has a promising outcome, such as a healthy patient who fell ill to coronavirus, and the only issue is their lung oxygenation, and all the other organs are healthy. But if there's a patient who has, let's say, a poor prognosis, poor outcome, is expected not to survive even on a ventilator, and has multi-organ system failure, they are not candidates, and it's for many reasons. And as we said, it's a multidisciplinary approach. Survival rate is anywhere from 50 upwards to 70%. It's a very expensive machine as well. It could cost upwards to $1 million per patient to operate. So the question that's on everybody's mind, can I have surgery safely today? And that's a very important question, because we all worry about going to the hospital. What's going to happen when we're in the hospital? Am I going to get the coronavirus if I go to the operating room? Am I going to get the coronavirus if I'm in the recovery room? How does this work? Well, generally speaking, since the pandemic broke out, things have gone a lot better. We've definitely have been able to manage this disease, and we've been able to get it under control. So all indicated surgeries, I would say yes. From my experience at the hospitals, at the ambulatory surgery centers, prior to the pandemic, things have gone better. Yes. All pre-surgical patients are tested. 2 to 5 days prior to coming to the hospital, they get tested, and then they have to sign a waiver that they are not going to come in contact with anyone who's high risk for coronavirus. They're going to quarantine, they're going to isolate, and then they're going to come to the hospital to have the surgery. Positive patients will be canceled and be safely postponed. Now, obviously, if there's an emergency, a patient has an urgent procedure that must be done, it will be done with precautions. The normal precautions that are being taken prior to current times where we're easing up on the restrictions. So all healthcare staff are screened for COVID-19 regardless of symptoms. Adequate PPE, which is personal protective equipment, includes the mask, shields, gowns, gloves are provided to staff and some of the patients if they need it. And there has been little to no evidence suggesting that providers are passing the virus to the patients. So that's something that should put a lot of the people who may have to go to the hospital for labor or delivery, they may be worried that they may get it from their doctor or anesthesiologist or the surgeon. That there hasn't been any evidence of that. It's because we're taking all the necessary and proper precautions. Visitors are restricted, and that is to minimize exposure to the virus. Overcrowding is avoided in hospitals to ensure adequate capacity. And another question is, what are we as intensivists, surgeons, anesthesiologists, nurses, what are we doing in the hospital to keep patients safe? So many of the things that we're doing. So as we said, COVID patients are identified, isolated, and treated. Negative COVID patients, we assume they are positive. We don't treat them as if once they tested negative, we can ease up and relax. We still treat them as if they're positive, because there have been cases of false negative tests. So it would be a false sense of security to think that, oh, somebody is negative, we don't have to wear an N95, we don't have to wear a PPE. So operating rooms are very well disinfected, and operating rooms utilize something called negative pressure airflow. Negative pressure airflow is in a way designed to prevent any aerosolized viral contents from escaping the operating room and infecting the outside atmosphere or exposing others unnecessarily. There's another interesting piece of device that I think is very important. It's called a HEPA filter. The HEPA filter is attached to the anesthesia machine and is attached to ventilators in the ICUs. It has a membrane that is hydrophobic in nature, which means that it binds to lipid soluble material, and the virus being lipid soluble will bind to this membrane and will not pass it and infect the machine. So every case that we use on a patient that needs general anesthesia, we attach this filter and we protect the machine, we protect the patients by protecting the machine. And anesthesia machines are disinfected between cases. That's a regular thing. Northwell Health alone, which is the company that I work for, along with North American partners in anesthesia, has been backlogged for over 10,000 urgent and elective surgeries from the start of this pandemic. Governor Cuomo recently eased restrictions on elective surgeries and ambulatory cares and has deemed them to open. Nassau County is included. With that said, I think from my experience, from what I'm seeing, we are definitely moving in the right direction. Thank you. Questions will follow.
Thank you, Dr. Barzida. Great presentation. Let's share. Can you remove your screen so I can share?
Yes.
Share screen. TV, share. Okay. Okay, so thank you so much to all the panelists. Great presentation. I hope people are a lot more informed right now. We had a lot of questions that came through. Unfortunately, time is running out. We'll try to add another 10-15 minutes if it's okay with Tova, and answer some of the common questions that came through. Anybody who would like to add on to these answers and questions, please go ahead. The first question was, is swimming in the swimming pool okay? I guess the more goes to Maytal Barzida, who's a pediatrician. What do you say, Maytal?
So we don't think that the virus travels through the water, especially if it's chlorinated. But if children are close together in proximity, they could still certainly pass the virus along to each other. So I would say with social distancing, it's probably okay. I would wait, however, until the case rates come down a little bit. So let's see how how it is when summer comes and what the numbers are.
So far to date, if the swimming pool kept clean and either chlorinated or salt water, there has been no reported transmissions through the water. However, once they come out of the water, it's a different story. So they have to be careful with the social distancing and stuff. The second question, somebody asked if they're in the hospital and require blood transfusion. Has there been any report of transmission of the COVID-19 through blood transfusion? And the data that came out in the presentation by University of Utah, they said there was no cases reported so far of blood transfusion causing COVID-19. So the blood transfusion is still safe. What is going to happen once we go back to work? So I will open this because it's a big question to all the panelists, and you guys could say what do you think is going to happen now that the country is about to reopen? What do you expect? I guess we start with Alan and we go up.
Well, I think once we go back to work, we still have to maintain social distancing, wear a mask. It really matters how where you work implements these things. I've been going to work since day one. I haven't stopped working, and we do a lot of disinfection in the office. Everyone wears masks, and I feel if you take the proper precautions, then it should be okay. I mean, obviously, we'll probably see some increased cases, and that's something that we're just going to have to accept if we want to go back to work. But as I said, it's going to take a long time to get the vaccine, so we have to keep living our lives and just take the proper precautions.
Thank you, Alan. Anybody else?
Yeah, I think that was, this is Dr. Amirian here. I think that was a great point. I think that what's going to happen once we get back to work really depends on where you live. And for people in Los Angeles and people in other metropolitan cities, specifically New York City, which is very populated and where people ride the subways, we really have to pay close attention to other countries that have started to try to reopen and really look at them very closely to see if there is a spike as the country begins to reopen and as people start to go back to work. So, other countries, we can look at Germany, Japan, and other countries as our model, so to speak, and look at their most metropolitan cities and try to use their cities as a model for us as we move forward. But the most important thing, as Dr. Khadavi mentioned, is never to have a false sense of security, to maintain social distancing, to take the proper precautions so that the efforts that we've all put in continue to work. Thank you.
Yes, basically there were some articles discussing that the number of cases and fatality and mortality were probably triple, goes from 100,000 currently to 300,000 cases, or maybe some studies go up to 1 million. So it's very, very important that we continue with the guidelines we presented tonight about being safe, wearing a mask, wearing gloves, social distancing, boosting your immune system. These are very, very important. I hope, it goes to people's mind and this way we could save somebody's life, but very, very important to stay safe and protected. And those who are really older, I don't know what age you call elderly. When they said 65, I don't agree with that, but whatever age it is, you have to be careful. You have to stay home. You have to take it easy. If you don't have to go to work, if it was the time to retire, now's the time. It's better to stay and not going to work. But yes, the reopening will increase the number of cases. There's no doubt, but we have to be careful and you have to be vigilant about it. The next question is, what do you expect the vaccine to be available? Which we discussed that, and obviously would be expedited as much as possible, but it's not an easy process. When can we restart the kids' play dates? Dr. Barzideh?
Yeah, so I mean, again, with back to Dr. Amirian's point, I think that is going to depend on kind of where you are. I mean, in New York City, that's where we're seeing the crux of this pandemic. So that's going to be probably there's going to be a different answer for New York City kids than, Long Island kids, than upstate, kids upstate or kids in California. There's always going to be a risk as long as this pandemic is here and as long as we are where we are, there's going to be a risk. I think if your child is completely asymptomatic and, is really not showing any symptoms, obviously the risk is less, but I can't say that the risk is going to be zero. So once we start to see the numbers kind of come down a little bit more, then it's going to be more safe. And at the end of the day, it's probably going to be really when the vaccine is out. When we have a vaccine, that's when we can do whatever we want, I think. So at this point, it's still hard to say, but I think it's going to take a little bit.
Another $1 million question is, when can we safely travel? Anybody has an answer? Well, I think traveling, as far as wearing a mask and gloves and you're keeping 6 feet away, they said within the first 2 rows from each other might be a spread, but otherwise you won't. So I think it's okay to travel with face mask and gloves and be careful. And but just for leisure, I think I would take it easy for a while to see what happens after reopening.
Yeah.
When is it safe to go to restaurants? So the restaurants are making a huge initiative to do the social distancing and putting tables apart from each other. Only family members are allowed to sit next to each other, and they want to 6 feet away. And so the capacity is going to be much less than it used to be, but they keep the distance. Now, would you trust the people who make the food and touches the dishes and stuff and what they bring to you? I guess it's a little bit hard for some people to appreciate or do it right away. And again, gloves and mask and stuff, that should be obviously when you eat, you can't put on your mask. So that's to be determined. I don't know. There's no clear answer to these questions, but they're all outstanding questions. The other question is public transportation safe? Dr. Khadavi, do you guys use public transportation in Los Angeles?
No, we don't.
You don't have that problem.
We only drive.
Yes, in New York, using the train, obviously, if you have no choice, again, they're trying to clean up and disinfect, but, I don't believe that they could do an excellent job, but they are doing their best. Again, not touching anything, wearing gloves, wearing masks, being safe. If you have an option to use personal, and the traffic is not bad, I guess go ahead. But if you don't have any choice, that's the way to be done, again, to wear the mask and gloves and stay safe. A few other questions that came tonight. was asked if corona is going to recur in the fall and what can be done to decrease the exposure. Dr. Khadavi, you want to answer that?
I think with the colder weather and more people, and if the restrictions are loosened, I think we're probably going to have increased cases at that point. I mean, we still have to be vigilant and do all the things that we've been doing, but it wouldn't be a surprise if we have more cases at that time of year.
Right. So, yeah, so I think if we continue what we're doing, I think we should be okay in the fall, and again, protect ourselves with all the precaution. Now, opening a school. Somebody asked if the school is going to open in September. What should we do with our kids? Is it safe to send them to school, Dr. Barzida?
It's a really good question. I mean, at the end of the day, it's not really going to be up to us. It's going to be up to the Department of Health and the political powers that be. Hopefully, by September and by the end of the summer, the numbers will come down. There have been new studies actually coming out that are very interesting that talk about how children are not the vectors that we initially thought them to be. So actually it's less likely for them to become infected, and it's less likely for them to be infectious to the people around them. So hopefully we'll get some more data on that specific topic. And when we do, hopefully it'll drive the answer towards yes in the fall.
Thank you. Somebody asked, how can you get your sense of smell back if you lost it due to corona? I think according to literature, 85% of people will get those senses back. And I think it might take as far as 5 to 6 weeks. But do you guys have any answers to what can you do to expedite to get the smell back? And what would be if it never comes back?
I work with an ENT, and I believe he spoke to me and he told me it's just time. You just have to give it time and it will eventually come back on its own.
And it's a gradual thing, I think, that gradually you start smelling some stuff and gets better or tasting. So majority will get it back. My answer is don't get panic about that, and you will get it back probably. And then another question, well, I hope it won't be political. Somebody asked Trump and some they would take hydroxychloroquine as a prophylactic. Are they wrong? Dr. Amirian.
So, taking hydroxychloroquine is not FDA approved. But if you decide that with your physician that you should be on hydroxychloroquine, I always say we need individualized care. So there's not a cookie cutter answer for every single person. And so until we have more data, if you and your physician decided together that you're going to be on Plaquenil, then you need very close monitoring and you need to take the right steps because there are serious consequences to taking this medication. The Heart Rhythm Society has issued a warning with regards to this medication, amongst other cardiology cardiology groups. So I do not recommend it. We need more data, but only time will tell. So we have to go based on data as scientists, as medical professionals. But there's not one answer for every person. So if you are going to do it and use it in a mild case, for example, you need to do it under the strict guidance and supervision of your provider.
Yes, because there's two major side effects that can be problematic. One is arrhythmia, one is retinal toxicity.
Correct.
So, but those two could be problematic. And if you're young and healthy, you just don't want to expose yourself to it because you're most likely going to recover and do okay. Now, elderlies, maybe different story. And those they should ask their primary care doctor, see what's the best thing for them, what they advise to do.
100% correct.
Yes. So I think we went over our time a little bit. So we were supposed to be done by 9, and we I think left it. It told us we could go as far as 9:15. I think we're gonna stop here. I thank IAJF for this sponsorship. IAJF really a great society, I should say, and excellent board. The boards are very smart, very educated. I often can't talk in front of them because they're all very smart and very educated people. And I thank this opportunity to talk here tonight. And a specific thank President Stephen Khadavi Mr. Hersel Torkian, who worked very hard and is monitoring us very carefully right now. Our chairman, Sharam Yaqubzadeh, our past president, Robert Cohen, and all the boards that I'm not going to have time to mention. Thank you so much again for this sponsorship. I hope this initiate more people to come out and help the community and improve our knowledge in any field, not just medicine. There are many knowledgeable people in our community that need to communicate and help people to, having a better and more successful community. So thank you so much. Thank you to all the panelists. They really work very hard at this. PowerPoint presentations, very nicely presented. I hope that we increase the knowledge of people, and I hope that we can be able to do it again. And again, please show your support for IAJF, sending donation, whatever you can do to help. And hope we can do this soon again. I wish everybody a wonderful Memorial Day weekend. I hope you can go back to beaches and enjoy, but keep the social distancing, keep your mask and keep your gloves. Thank you so much, and wish everybody a good night.